Yes, we debated this this morning, and it's clearly the breakthrough therapy in patients with relapsed ALL, and there's extremely promising results, of course, in relapsed NHL, high-grade NHL, and so the debate here in those areas has been, can you move this therapy forward and possibly even use it as front line in place of an allograft in the setting of ALL. We're lagging behind in AML, and that's largely because antigens are shared on leukemic blasts and stem cells with normal hematopoietic cells. And so there's this major risk of aplasia, not in itself disastrous if you're going to follow up with a transplant. And Gil presented some really compelling data around their Phase 1/2 studies generating a CAR T that was recognizing CD123 and some encouraging results. But I think there was a consensus view that this is going to be an important contributor going forward, but it's very early in its days, and my position in the discussions was that whilst it is developed as an effective and tolerable therapy, we should also focus on how do we ensure that we optimize outcomes in patients allografted for AML. And I think there's a lot of space there. There's a lot of work to be done. So some of the considerations are, what do we do with patients who are in remission, first remission? Do we take them to transplant in first CR if they're MRD positive? And I think there was pretty much a consensus view that there isn't any evidence that in patients who are MRD positive pre-transplant, any further chemotherapeutic intervention or even targeted therapy is going to improve outcome. No randomized data. And instead, it's emerging that the outcomes for MRD positive patients, although the relapse risk is higher, we showed in the FIGARO trial using immunophenotypic determination of pre-transplant flow MRD, that the cumulative incidence of relapse if you're MRD positive went from 20% to 40%. But the 2-year overall survival for the MRD positive patients was still 50%. So actually get them to transplant as quickly as you can, and then think about either using a myeloablative regimen if they're MRD positive, or manipulating the transplant. So maybe withdraw immunosuppression early or consider DLI. And those are areas I think where we do need further randomized trials. There is a UK study through the Impact Network called PRO-DLI, where Victoria Potter's led a study randomizing patients to have an early cyclosporine taper with prophylactic dermal lymphocyte infusion. The results of that study are awaited. And it's that sort of consideration about how might you augment a graft versus leukemia response post-transplant that's so important. And what's supportive of that approach is the data we got from FIGARO showing that in patients who are MRD positive pre-transplant, the relapse risk if patients achieved full donor T-cell chimerism at day 90 was the same as if you're MRD negative. The patients who did really badly were those who were MRD positive and didn't switch full donor chimerism. So that supports this post-transplant intervention strategy. So I think that's one really exciting area. I think there's some other data that was discussed at this meeting that has been collected by Rob Wynn from Manchester in the UK, where he and the UK group have got some really exciting outcome data in pediatric high-risk AML. And they have shown a very substantial improvement in disease-free survival, like about 30%, using a single cord as opposed to other stem cell sources. So Rob is proposing with the French colleagues a randomized study in that population. So stem cell source may be important. And we also discussed in some detail in patients who are FLT3 positive, the clear evidence now that maintenance therapy with Sorafenib improves survival. We're awaiting the results of the MORPHO trial, we hope next year, using Gilteritinib. And then you move towards the consideration of which approach. Is it a targeted TKI or is it a broad TKI with broad activity, multi-kinase activity? I think there was a general view that it's a bit of a moot point that the important thing will actually to get approval for using these drugs, and that there may be toxicity issues determining which one you adopt. But I think it is important that those two randomized studies have shown improved survival with sorafenib, so that points the way. So I think it's an area of great excitement. The possibilities to improve outcome are now emerging through optimizing conditioning regimen, manipulating the immune response post-transplant, thinking about optimal cord, optimal stem cell supply. And it just underpins really the importance of randomized clinical trials if we're going to get on top of this question. I think there was a general view in this meeting that retrospective studies can be useful, they can be good in hypothesis generating, but what we need is these large prospective randomized studies, just like would be routinely adopted in AML or myeloma or other diseases, if we're going to really understand how to improve transplant outcomes and also deliver really important translational studies.